So radiofrequency ablation and resection are two good options for patients with early stage HCC or even a bit larger stages. But the problem is, I think we know they are really comparable concerning the oncological outcome. However, we have to consider some special parameters of the patients. Radiofrequency ablation is probably very good in patients who have advanced cirrhosis, if they have severe portal hypertension, when they cannot do resection, and in patients who have comorbidities, namely lung disease or chronic heart disease. In these patients, you cannot do surgery. So I recommend to do, in this kind of patients, I recommend to do radiofrequency ablation. In patients who don't have fibrosis, who are fit, younger, and do not have portal hypertension, I would recommend to do the resection. So I think there's no good consensus, and I think it's always depending on the center of where the patient is treated. But in the end, in every patient in which you consider treatment, such as radiofrequency ablation or laser ablation or microwave ablation or surgery, you should have an interdisciplinary tumor board. And in this tumor board, there should be a interventional radiologist and also a surgeon, a hepatobiliary surgeon who is quite familiar with doing liver resections. I think this is the most important conclusion for me if you consider ablation or resection.
Patients with small tumors are good candidates for local therapies. That could be either surgery or radiofrequency ablation, and sometimes other techniques such as microwave ablation are nowadays used. The decision what is the best treatment really depends on the tumor, and again we have to acknowledge both the underlying liver disease, the remaining liver function, and also the tumor. And for the tumor we specifically have to see where the tumor nodules are, if they are more central or more at the periphery of the liver. And based on that, we can make the decision what would be the best approach, surgery or radiofrequency ablation. In general, radiofrequency ablation is recommended for patients with tumors smaller than 3 centimeters, because we know if they have larger tumors, they have microsatellite metastases around the tumor, and the chance that we really get a complete destruction of the tumor is significantly lower than compared to patients with smaller tumors. When we have really small tumors, 1 to 3 centimeters, the decision between radiofrequency ablation and surgery can also depend on the availability in the specific hospital. If you look at the outcome in long-term retrospective studies with a lot of patients, it seems to be very equal. In general, surgery is always a little bit better, but not that good or so much better that we could recommend that everybody needs to receive surgery. So I think both treatments are very good options for patients with small tumors.
So I think adjuvant treatment is really important for patients with HCC, because we learned from the STORM trial that patients have a high rate of recurrence. So even in patients who got complete resection and complete ablation, we had in the treatment arm, but also in the placebo arm, the patients were treated with sorafenib, high rates of recurrence. The recurrence-free survival was less than median recurrence-free survival was less than 3 years. That means more than 50% got recurrence within 3 years. So this is a really unmet need, and I think as we have really potent treatments with immunotherapy will be the way to go. And I think there will be immunotherapy such as PD-1 antibodies in the monotherapy, but also according to the melanoma trials, I think there will be also a combination of checkpoint inhibitors such as pembrolizumab or nivolumab, and also a combination with ipilimumab, CTLA-4 antibodies. So I think the immunotherapy will be the way it goes.